All right, we're going to go ahead and get started. This morning, we have a very special guest, Dr. Kaitlin Bevers, a product of our training program. She is somebody to be very, very proud of, and she's one of many examples, actually, from our various training programs in the Department of Surgery. And you know what a lot of people probably don't know about me is, yes, I'm proud of how many pancreatectomies or liver operations I do. Yes, I'm proud of how many, departments, centers, or whatever I help run. But what I'm most proud of are the trainees that come through our general surgery training program, our urology training program, our plastic surgery training program, and all the programs in the Department of Surgery. And, you are our future, along with many in this audience. And, one day when I get sick, I'm going to be depending on you. So I'm going to turn this over to Dr. Mark Naylor, the program director for the department for the general surgery program. And he has done such a terrific job of building our general surgery program and really recruiting the brightest and pushing them off to great fellowships or jobs. And thank you, Mark.
So first I want to acknowledge Dr. Liz Kovacs. This was her idea to bring alumni back to discuss surgeon scientist careers. So thank you. This is our second visitor. Last year we had Taylor Ripley who came from Baylor. So Dr. Bevers did her undergraduate at University of Michigan, and then she did her medical school training at Wayne State, and we were fortunate to recruit her here for her general surgery training. And during that time, in addition to being an outstanding resident, she spent 2 years as a research fellow at the National Cancer Institute in Bethesda. And at that time, I believe she was named the chief fellow, so ran things from the fellowship perspective, just a nod to her leadership skills. Then she did her thoracic fellowship at Memorial Sloan Kettering after finishing general surgery here. And now she is a assistant professor at Duke and Division of Cardiothoracic Surgery, as well as part of their Cancer Institute. So very excited to hear her talk today. So thank you very much for making time, and let's give a welcome to Dr. Kaitlin Bevers.
Is this working? Yes, great. Well, thank you all very much and for the kind introduction. And it's so exciting to see all these people that I know and in this space that I know very well. And it's an amazing honor to come back and be in this position, in this room. I can't tell you how flattered I am to have been asked to speak today. And I certainly hope I can live up to the honor of the request. I'm hoping to talk about a number of topics today related to how I've tried to approach starting to build a career as a surgeon scientist, and then through this to talk about some what I think is very exciting information about my personal love, what my research focuses on, the biology of small cell lung cancer. So to start off, I'm a surgeon whose research focuses on a non-surgical disease. And I'd like to talk a little bit about why I think this actually isn't a futile approach to trying to build a career as a surgeon scientist, especially when you're early. And so currently, small cell lung cancer only has limited recommendations for surgical treatment. And I started on this field from a research perspective by chance as a result of projects that I was associated with during my research years at the National Cancer Institute, as Dr. Naylor alluded to. I kept moving forward with it because I felt that the associated science was particularly interesting. And in my mind, the point of doing or participating in a surgeon scientist career is so that you can do fun science. So if you're not doing something that is interesting to you, it's probably not worth doing. And so today I'd like to discuss the state of science in small cell lung cancer research and the areas that my team hopes to make further translational and ultimately therapeutic benefits. within this field. And then along the way to explain my journey and to see if that can help to explain why surgery may become important in small cell and how understanding its biology will let that translation happen. And I also hope to convey to any aspiring surgeon scientists in the audience that though I'm still early in this process, that I think focusing on a condition that no one else really cares about or doesn't seem to care about is a good approach for someone early in their career, as long as you have a biologic reason to do so. So this is something everybody realizes, but to start off, when you start off in a research career or any academic career, you need to identify your niche or the particular question which is meaningful enough that you'll be able to produce value by your work, but that also is concise enough that you'll actually be able to tackle it, starting out with the limited resources that are available to you. So you're going to have limits on time, money, space available for you to do research, the staff that can help you, preliminary data that already exists. And I'm going to say now that this is much easier said than done. And for those of you who are early or even before early and thinking about this question, it is as hard as you think it is. And this is the hardest part of the entire process. But it's critical. And an additional parameter that weighs into the decision of what is associated with this idea of value pertains to how different your question is compared to the current work of all other stakeholders in the field. And there are forces from all corners in direct competition with you for grants and tissue, patients for clinical trial enrollment, value for publication. And this doesn't just pertain to cancer research as demonstrated in the diagram, but all biomedical research. And when you're early and new and you don't have the money to do massive omics translational work with multi-institutional tissue banks that cost millions of dollars, or connections and clout in industry in order to fund multi-institutional clinical trials, how are you supposed to create value when what you have are Western blots and flow cytometry and clinical databases? And you're not competing with just surgeons, but everyone who's interested in the disease that you're interested in. And I suppose that if the timing's right or you're extremely clever, you can sometimes find a tiny area in an already saturated disease field that hasn't been touched and go from there. Or you can try to look somewhere else that no one wants to look and see if there's a way forward. So as a little bit of background, of all the thoracic malignancies, small cell lung cancer is certainly not the most common, but it is the deadliest. 7% of all diagnosed lung cancers per year are small cell lung cancer, but 25% of the deaths due to lung cancers are due to small cell lung cancer. And this averages to approximately 30,000 deaths per year in the United States. And the average survival from diagnosis is only about 10 months, and the 2-year survival rate in small cell lung cancer is currently 6%. The standard systemic treatment is a platinum etoposide chemotherapy combination and has not changed significantly from its institution 4 decades ago. And even though 80% of patients demonstrate a response to this treatment initially, they ubiquitously develop primary and cross resistances to other therapies, and patients universally succumb to their disease. And small cell lung cancer is known to be highly metastatic, with a vast majority of patients being diagnosed at late stages of the disease, as we can see here on this graphic, which is a little bit old, but still, we're looking at 95% of people in a late stage. And due to this, the original staging system, which is actually used in many places and in publications still today, actually was only binary and defined the stages as you can see here, limited versus what's called extensive, which is the same as stage 4 disease. Sometimes the staging system for non-small cell lung cancer, which is listed, I don't know if this is going to work, but it's listed on the left side of the screen here, is applied to small cell lung cancer. And as it can be seen, it does actually stratify survival, suggesting that early stage small cell may actually have a different behavior and may benefit from more aggressive intervention very much. So while earlier stage 1 and 2 disease has traditionally been uncommon, as I mentioned, sort of 5% is listed on this graphic here, the growing application of low-dose CT scanning for lung cancer screening, as well as something we'll talk about a little bit later in the talk, but the new identification of an early stage small cell tumor arising as a recurrence after targeted therapy resistance in the more common non-small cell lung cancer has made the presentation of potentially resectable small cell lung cancer more common in the thoracic surgery clinic than ever before. And in general, clinical trial work in small cell lung cancer up until this point has focused on applying agents to improve outcomes in the metastatic or extensive stage setting, as well as more commonly in the recurrent state of the disease after it's become resistant to chemotherapy. Recently, checkpoint blockade with PD-L1 inhibitors was added to chemotherapy as first-line treatment for metastatic small cell lung cancer. However, this has been found to only improve median survival by 2 months, and only 12.6% of patients have been seen to be progression-free at 1 year. In the setting of recurrent resistant disease, there are currently 3 FDA-approved therapies. The first one is topotecan, which is a topoisomerase 1 poison, and this shows transient responses in 25% of patients, but there are substantial toxicities associated with this, and it's not used that commonly. The PD-1 inhibitor, nivolumab, has been studied, but the durable benefit in patients is less than 15%. The most exciting advancement has been in the last year, and there was FDA approval of what's called a biphasic T-cell engager, or a BiTE, which is called tarlatamab DLLE. And this is basically an antibody conjugating drug that engages a protein that's expressed ubiquitously in the body called DLL3, but is specifically expressed on cell surface uniquely in small cell lung cancer. And the second arm of this drug simultaneously targets CD3 on T cells, and this brings T cells into the proximity of cancer cells, both to help with just the geography of the tumor microenvironment, but also to enhance the T cell activation. There has been a lot of excitement for this because the study that evaluated this drug showed for the first time actual significant radiographic response in disease of patients who had previously developed resistance. However, the study was not powered to actually demonstrate whether or not there was a survival benefit, and it is known that there are significant cytokine release syndrome complications associated with this drug. But at this point in time, tarlatamab is hot commodity, and it is the standard treatment for patients who do have recurrent state disease. The current clinical management standards for small cell lung cancer recommending limiting surgical resection to lesions 2 centimeters or less in size and in the periphery of the lung without any evidence of local or distant spread. So that's as listed up here. Small cell lung cancer, because of its aggressive nature, requires an extensive array of tests to make sure that patients are staged properly. So in order to truly determine whether or not someone's resectable, they do need to get a PET CT scan. They need to have invasive mediastinal staging with tissue sampling with either endobronchial ultrasound or mediastinoscopy of their central lymph nodes, and all patients get an MRI of the brain as well. The recommended limitation for doing resections to only lesions associated with the periphery of the lung is based on observations that lesions that appear within the central third of the lung are more aggressive and highly metastatic. And so patients tend to be limited from that perspective. At this time, lobectomy is recommended due to the concern for recurrence because of the aggressive nature of the disease. And though a direct comparison of sublobar resections actually hasn't been performed, so we're not 100% certain if lobectomy is truly necessary. Even after resection of these small tumors, adjuvant chemotherapy is considered the standard of care. I apologize. Central or larger stage 1 lesions and all stage 2 and 3 lesions are recommended to get combination chemoradiotherapy and can have the addition of prophylactic whole brain radiation included with this due to the risk of cerebral metastasis, but the data on that is mixed, and so it's not always applied. And then in stage 4 disease, we discussed the combination of chemoimmunotherapy is standard, and then recurrent disease has the 3 options as mentioned. This graphic was produced before tarlatamab became ubiquitously used. And again, tarlatamab tends to be the predominant agent that's used in today's day and age. So I started my career studying small cell lung cancer at a time when many of the lung resections were done for the disease were done by accident, either due to an incorrect or absent preoperative diagnosis. And the most that we understood biologically about the disease is that the cell lines which had been generated in the 70s and 80s by 2 gentlemen named Drs. Mina and Gazar at the National Cancer Institute had appeared to appear in 2 different subtypes, which they termed classic invariant. And they described the different growth patterns associated with these, and that's how they created this stratification. So classic cells tend to clump together and grow in these sort of groups, whereas variant lines tend to have these more linear paths. Some superficial or initial evaluation of the differences between these two things suggested that there was a correlation between chemo and radiosensitivity. So classic cell lines were noted to be chemoradiosensitive in comparison to variant, which were resistant. Classic cell lines also showed a slower doubling time in comparison to the variant. And classic lines demonstrated no neuroendocrine markers, which was expected because small cell lung cancer in general histologically is classified as a neuroendocrine cancer, whereas the variant lines had lost this expression. So I walked into my assigned laboratory at the National Cancer Institute in 2016, and I was presented at that time, having no idea what I was going to be studying at all, with the general results of a massive whole transcriptome analysis that had been done by the lab. And the lab had included a series of cell lines with a bunch of different thoracic cancers, esophageal cancer, non-small cell cancer, small cell cancer. And by chance, a PhD who worked in the laboratory, just out of interest, technical interest of his own, had generated what's called an induced pluripotent stem cell line from normal human lung cells. And so he took a normal human cell from a person's trachea and using transduction of a series of factors, turned it basically into a stem cell with all normal stem cell functionality. And for his own interest, he asked that line to be included in this massive transcriptional analysis. And so significantly, what we found associated with this was that there was an extremely high correlation between the transcriptional profiles of the small cell lung cancers and the induced pluripotent stem cell line. And this was an early suggestion that small cell lung cancer biology was likely related to reprogramming to a stem cell-like state. And for me at the time, this opened up the possibility that some sort of cellular reprogramming was happening between these two subtypes, the classic and variant subtypes. The behaviors of the cells were potentially relearning what at the time I thought was maybe a neural crest cell program, which allowed them to learn how to leave their native state and metastasize, and then to show distant organ tropism, which is what we normally see in the normal behavior of the neural crest. Even at the NCI at this time, I was constantly asked why I did a research project and focused on a non-surgical disease. But then I rationalized to myself that it was a disease that was currently without hope for patients. And there were indications from our work of a biology that I found really interesting. And not only interesting for the sake of itself, but a biology that might explain metastatic behavior in general. And so I thought that was enough of a reason to dedicate time to it and to potentially use it as a model for the idea of cancer metastasis overall. Simultaneous to the initiation of this work, and over the next series of years when I came back to clinical training, huge advances were made in the biologic understanding of small cell lung cancer. And of course, unfortunately, I was not in the laboratory to see them. And so as a note to all of those who are still in training and who are at that phase in their life, I was very concerned when I came back to clinical work that I would lose my connection to the progress of science. I was telling people I wanted to be a surgeon scientist, but I didn't know how to stay engaged or how I could come back into a lab setting as an independent researcher once I graduated and be competitive against those who had never left the field. And I'll be honest, I asked a lot of people at the time how to approach this, and I think it was hard for people to give me practical advice. And I think this is because it's a very difficult question. Surgical training is and needs to be so time demanding in order for us to develop independence in a highly risk associated field. And it's difficult to continue to engage at a meaningful level in the lab. And especially here, now that the program here is a dedicated 7 years, some people have the benefit of still being physically close to their lab, even when they return to training, and this probably helps to stay engaged. For those that aren't, I would say that the main advice that I can give is to do your best to attempt to attend lab meetings, even virtually, and to read. I know that's what you're told about everything, but read as much as you can and ask previous mentors to continue to provide you with important manuscripts that are coming up so you can at least look through and see where the state of the science is going. And also ask them to help or to ask them to ask you to help them review articles in your area of interest, because that will keep you open to what people are doing. And it's not just the state of the disease you're thinking about, but also just the technology that exists within the research field to learn what is available and what new technology can be applied. So at the same time, in addition to the biologic advances in small cell lung cancer, which we'll discuss in a minute, some signals started to arise of an expanding interest in surgical indications within the treatment of SCLC. And a series of clinical papers listed here, which were based on evaluation of the general thoracic surgery database from the Society of Thoracic Surgeons, were written fortuitously by the group that would eventually become my partners in practice. Overall, their work suggested that surgery may actually contribute to improved survival in an expanded number of small cell patients, and at least in patients that were noted to be node positive or N1 positive small cell lung cancer, in a general belief to the contrary. When looking at clinical databases, of course, this can only be a suggestion of a possible expansion for surgical indications. And while this data had a large sample size and was relatively strong, indications for surgery haven't changed, obviously, based on this. And this is also largely due to the fact that we've been taught that small cell lung cancer is a homogeneous single disease, and a very aggressive one at that. And so it is challenging to understand why these clinical findings may actually be true. And it's here that the current progress in the biologic understanding of small cell lung cancer comes in. Of note, and we'll mention him later, Jeff Yang, who is faculty at MGH, still remains very focused on evaluation of clinical utility in surgery in small cell lung cancer, and is an excellent partner in this work. So when we think about the much more common type of lung cancer, non-small cell lung cancer, great progress has been made in clinical outcomes for patients in the last decade or 20 years or so. And this is largely for two reasons, I think. The first one is that subtypes of non-small cell lung cancer have been identified, and they're based on genomic mutations, which are usually associated with activated oncogenes. So the classic ones that we think about in the surgical realm are EGFR and ALK. And drugs have been created which target these, blocking their effects, and you get excellent results for patients. The second issue is that much of non-small cell lung cancer is known to be immune hot, or at least immune warm. And so the checkpoint inhibitors tend to work well in this disease. One of the biologic advancements that small cell lung cancer saw in the middle of the 2010s was the completion of whole genome sequencing of human tumors of this disease. And it had been known before that small cell lung cancer pretty routinely demonstrated loss of the tumor suppressors TP53 and RB1. And this work reiterated that. However, even though there was a significant mutational burden in small cell lung cancer overall, which we would think would maybe matter from an immune perspective, a lot of times we say heavy mutationally changed tumors have a lot of neoantigens that make it so that immune therapy tends to work. That doesn't end up being true in small cell, but we'll talk about that a little bit later. There were no consistent genomic changes that let the cancer be stratified into subtypes. And there were no changes that were activating in oncogenes. And it's not possible currently to give medications that turn on tumor suppressors that have been turned off in the same way that it is to pharmacologically block oncogenes that are activated. So small cell lung cancer was left at a therapeutic standstill with this data alone. And of interest, this work did suggest that there were mutations that were pretty common in epigenetic modifiers, right here, in small cell lung cancer. But we didn't really know what to do with that at this point. We still don't really know what to do with that, but it's an interesting thing to comment on. So that was interesting biology, but it didn't lead to any benefits in terms of really understanding what to do. The first groundbreaking advancement for the understanding of small cell lung cancer biology came from an attempt to define the transcriptional and epigenetic landscape of small cell lung cancer. And it was here, rather than in the actual genome, that isolated subcategories of behavior were noticed in small cell. Eventually, after extensive validation, this model is based on many, many, many papers, a classification system was born for small cell based on expressed proteins, which are now referred to as the lineage transcription factors. And these four factors are ASCL1, NeuroD1, POW2F3, and YAP1. ASCL1 and NeuroD1 have been associated with concomitant expression in a subtype of MYC known as L-MYC, which is this sort of dark yellow here. And tumors that fall into these categories are noted to have a neuroendocrine-like behavior. POW2F3 and YAP1 have been shown to be associated with expression of, as in the bright yellow here, the subtype of MYC known as c-MYC. And they have a less neuroendocrine behavior and a more stem cell-like behavior. Outcomes in the ASCL1 and NeuroD1 high types tend to be associated with the outcomes we saw in that classic subtype within the cell lines and are better. They are more chemotherapeutic really responsive, whereas POW2F3 and YAP1 show poor response and are more similar to the variant types that we talked about before. And this was the first indication that small cell lung cancer is actually heterogeneous and that treatment probably needs to be tailored to these subtypes in order to improve outcomes. So the vast majority of the work that led to that model development was performed by this gentleman. His name is Charlie Rudin. He is a medical oncologist, an excellent and very high-powered medical oncologist at Memorial Sloan Kettering. He was also the driver behind the checkpoint inhibitor immunotherapy clinical trials in small cell lung cancer and is the founder and leader of the National Cancer Institute Small Cell Consortium, which is currently the centralized group focused on translational research in small cell in the United States. And it was mostly by chance that I came across him in my work during my fellowship at Memorial Sloan Kettering. And he was kind enough to let me join into his lab meetings when I could. And I made sure to keep up to date with what he was publishing in an attempt to stay current in the state of small cell lung cancer. The second important biologic discovery in small cell lung cancer arose from the subtyping that we just described. So there was a group that developed a genetically engineered mouse model for small cell lung cancer, which forced overexpression of c-MYC. And we have this as reference again. These are the classic invariant lines. RPM is the c-MYC overexpressed mouse. RPR2 is a non-c-MYC or a c-MYC wild type mouse. And both of these mice are designed to produce small cell lung cancer tumors. And what was noted is that in the RPM or c-MYC overexpressed model, when these tumors were taken out of the mouse and left to grow in a dish, they spontaneously, without any intervention, went from a classic to a variant subtype on their own. Whereas tumors that did not have c-MYC changes stayed the same. They stayed in the classic position without any change. On top of this, a time course evaluation in the expression of those lineage transcription factors that we talked about was done over the course of this change, and it's demonstrated here. And what it ended up showing is that tumors in this early stage express ASCL1, and as they go through this transition, they lose ASCL1, they gain NeuroD1, then lose NeuroD1, and they gain YAP. There was some complex computational analysis done associated with this, which ended up showing that a single cell could have this process happening within it independently without any interventions. The other benefit of looking at this single cell profiling shown on these mouse tumors ended up demonstrating that all of those subtypes, whether they were in what we call the A, N, or Y state, existed in a single tumor at the same time. And as I said, each individual cell could change from one state to another on its own. And this was the only influence that was necessary was the expression of c-MYC. This generated the current model of understanding of small cell lung cancer behavior, and it's a generally novel concept within cancer cell biology that small cell lung cancer is a highly plastic and a rapidly evolutionarily active cancer that changes by itself. And this ability to change is defined by the fact that its subtypes are defined by the easily modified transcriptional state as opposed to the genome. And it's likely controlled by irregularities in epigenetic modification. So what we're calling subtypes in small cell lung cancer exist, but they're transient and coexist within single tumors. And due to this, treatment in small cell lung cancer is likely going to have to be multifaceted and targeted multiple states at the same time in order to actually eradicate the disease. The c-MYC overexpressing mouse model described and the demonstration of this plasticity were both the product of the work done by this woman, Trudy Oliver, who is a leading cancer cell biologist in the realm of small cell lung cancer research. I feel like I say this word a lot, but also fortuitously, when I began my job search at the end of my fellowship, I was granted an interview at Duke, and I expressed my intention to develop a career as a surgeon scientist as part of that interview, and specifically my plans to focus on small cell. And by pure chance, 2 months before my Duke interview, Trudy Oliver had been hired as faculty at Duke, and she was coming from the University of Utah. Additionally, by chance, the day of my interview at Duke, she happened to be presenting at Cancer Biology Grand Rounds. And I was able to listen to her presentation of the data that we just described. While she was presenting that, I flashed back to my work done when I was in the laboratory at the NCI and my hope that a stem-like state was related to small cell lung cancer. And I will say that this was probably the first moment when I really felt true confidence that moving forward in this field was something that I could potentially do. Because of the timing, Trudy was building her lab and there was space for me coming in. For other reasons, she visited Memorial Sloan Kettering to present her work there at the end of my time in fellowship. So that was a re-solidification for me to have a landing zone for research as I accepted my position at Duke. A few other important biologic behaviors in small cell lung cancer have been described in recent years. As mentioned before, even though immune checkpoint and these biphasic T-cell engager therapies have been approved in small cell, the improvements in outcomes of these therapies are quite marginal, at least in late and recurrent stage disease where we've seen them applied. And this has been attributed to the fact that overall, small cell lung cancer is known to be an immune cold tumor, and very little immune infiltrate is seen in them overall, in spite of its high mutational burden, as we discussed. Further work done by Charlie Rudin and his group has demonstrated that the most immune cold small cell tumors are those that are in early stage, and predominantly those that are neuro-D1 positive. So we can see in this figure here, we have examples, these are human samples, of a neuro-D1 negative tumor, a neuro-D1 positive tumor. Hopefully you can see here that the lower panels show it a little bit better. But the green is immune in these lower panels, and we can see that there's basically no infiltration of immune cells within the neuro-D positive tumors. We also previously described the clinical benefits of targeted blockade for oncogene mutated non-small cell lung cancers, such as EGFR and ALK positive tumors. And the success of these therapies has been very dramatic and is now standard of care, as it should be, in adjuvant treatment of resectable and in all late stage disease in tumors that express these mutations. A relatively uncommon but an unexpected consequence of the widespread application of these targeted therapies, when they're given in localized tumors at least, is the development of recurrent disease, which actually comes back as a small cell lung cancer, as opposed to a non-small cell. And these small cells that return are resistant to therapies, and we don't know what to do with them. And when this recurrence does occur, in spite of their resistance, it tends to come back as local disease, an isolated spot in the lung in the area where the original tumor was. And in spite of the description of this phenomenon as being listed as a rare case report on the manuscript that I've presented, I've been in practice for 1.5 years, and I've seen this presentation 3 times in the course of just seeing patients through my clinic and my work at Duke. And as such, I suspect that this is a phenomenon that will begin to appear more commonly, and it will require engagement of surgeons due to the local nature and therapeutic resistance of these recurrent diseases. Lastly, a very important, huge study, and huge in the sense of how much work it took to complete, that was published within the last year, provided scientific evidence of what sort of in the undercurrents of small cell was a suspected reality of its biology, but no one wanted to admit to. And that was the idea that the chemotherapy that we were giving that led to this great radiologic response, but everybody ended up getting cancer back anyway, was actually the reason that patients were developing therapeutic resistance, that it was causing damage in the DNA that led to resistant profiles that eventually made the disease untreatable. So this paper did an extensive whole genome analysis on small cell lung cancer biopsies taken at multiple time points along patients' treatment course. So they took biopsies before therapy, during therapy, after response, and at the time of disease recurrence, when they had demonstrated a significant outgrowth. And what was noted was after therapy was given, there was a significant development of what they deemed genomically very different clones that hadn't existed prior to chemotherapy. So if we look at sample 1 up here, this is the tumor or the example of the tumor before the patient has gotten any chemo. And from a general perspective, so the black represents a single clone. Each color is a different clone. And as you can see, it's more homogeneous than in sample 2 after treatment has already occurred, when you start to develop all of this heterogeneity within the tumor. Of note, DNA damage patterns were evaluated in these tumors, and it was shown that the genomically varied clones that existed after chemotherapy showed signatures that are known to be associated with damage from the actual chemotherapy itself. So this group concluded that the clinical initial response that's traditionally seen in chemotherapy represents the death of a sensitive line that exists predominantly within small cell lung cancer, but that it either allows the outgrowth of a minority of cells or actually generates, which is their greater suspicion, a new cell clone associated with the chemotherapy-induced DNA damage, and that this clone has a high plasticity, which outgrows into these divergent clones, which are very different from one another and also all resistant to chemotherapy. So this suggests that it's likely important to consider identifying different therapeutic targets in otherwise untreated small cell lung cancer to actually aim for eradication of the disease without promoting heterogeneity, or at a minimum, to identify targets that can be given concomitantly with chemotherapy to completely eradicate the disease. And so it's here where my work comes in. My work in the lab focuses on the question, what is the biology of early stage small cell lung cancer before it metastasizes and even just before it becomes chemotherapeutically resistant? And is there a non-chemotherapeutic mark that can be targeted to totally avoid chemoresistance or to be given concomitantly with chemotherapy? And in some part, we are also looking into what cell state persists in spite of chemo or is caused by the initiation of chemo and how that could be eradicated. Late-stage chemotherapy and resistant small cell lung cancer is in many ways already out of the barn in regards to its biology. And it's hard to imagine that a cure exists in this space anytime soon, or even a drug development that's going to have a massive impact on survival. However, late-stage disease is the area of small cell where medical oncologists and cancer biologists focus their research, naturally. And as such, the biology of early-stage small cell has been generally neglected. And most of the SCLC community assumes that chemotherapy is good enough. So people really haven't been focusing on this area of the disease. And as surgeons, we offer the perfect perspective to focus on this early stage of the condition. We have the ability to obtain whole tumor microenvironment, lymph node tissue under clinically valid scenarios of resection in early stage disease. And by working on developing therapy specific to early tumor states, we can potentially improve outcomes that make surgery valid in a greater number of locally advanced scenarios. Additionally, we can help better determine if there are additional substates that exist within early stage disease, and that some of these may be more or less susceptible to surgical therapy, even in the current era of chemotherapy without other targeted agents. We're also critical in determining if small cell lung cancer, which occurs as a recurrence of non-small cell lung cancer targeted therapy resistance, behaves in the same way as traditional small cell lung cancer, and how surgery should play a role in that subset of the disease. We discussed how immune therapies have not done much for late-stage small cell, and that early-stage small cell is known to be even more immune cold than the late stages of the condition. However, since the treatments that we discussed that are particularly for late-stage disease or recurrent disease are new and FDA approved, and they've shown some signal, there are rising considerations from medical and some surgical thoracic oncologists in creating neoadjuvant trials that bring immunotherapies to locally advanced small cell lung cancer. And based on everything that we've discussed, this intention in my mind is naive and based on a design just attempting to shoehorn immunotherapy and surgery into a condition that, based on its biology, we have a low suspicion will actually work. And as a surgeon, I feel it's important to engage in this conversation to deter forcing surgery where it doesn't fit. Doing this will likely simply reinforce the existing idea that surgery has no place in small cell lung cancer management. So in a philosophical summary, sort of that general idea, and in spite of these two quotes being used close to probably exhaustion in the realm of surgical oncology, I think the ideas communicated by both of these things are used so much because they remain so true. So in this first quote, which in general summary is the statement that when you have a hammer, everything looks like a nail, which is attributed to the American philosopher Abraham Kaplan, and very appropriately, the turn of phrase was coined about medical research. I'd like to say that we can't let our arrogance about our technical and therapeutic skills and tools overshadow our understanding of our common enemy, which is the disease. And if we do, the disease will win because we are attacking an enemy, we are attacking an enemy that we don't understand. And this is not just true when applying surgery, but it's true of applying any therapy, including immunotherapy and chemotherapy. And this concept is, of course, summarized in the frequently repeated statement from the surgical oncologist Blake Cady that a disease's biology is king, and the powers of what he deems the prince and princess, which he calls technical maneuvers, can't overcome biology. And I would add the caveat to say it can't overcome biology when they're applied without understanding the biology. So in summary, from a biologic perspective, small cell lung cancer is a very deadly malignancy whose biology is just beginning to be understood. And it is not one disease, but is actually a very plastic disease that is able to spontaneously move between its subtypes. Most research has focused on late-stage small cell lung cancer, and this has been met with significant challenges due to a very complex and heterogeneous biology. And I do believe that surgeons are poised to unlock the biology of early-stage small cell to aim for a potential cure. And then from a more pragmatic end, in the concept of trying to build a career as a surgeon scientist, I will say that opportunity in developing such a career, while being driven internally, is important. It is not always related to just your own motivations, but is also related in some part to chance. And I fully acknowledge that almost all of where I've been able to arrive at my current career was based on people who somehow were placed in my path or around me as I moved through the structure of clinical and research training. And I think this is extremely common, and it makes it hard to, quote, teach people how to become a surgeon scientist. However, you can only progress if you actively engage and participate in all of those opportunities as they present themselves. So this is the area where you do have influence on what's going to happen in terms of your future. And as a trainee, I told myself that I needed to operate under the assumption that there was any chance that I was going to succeed as a surgeon scientist, it would have to be with moving forward with an external confidence and existence that what I wanted to study mattered and that it would work, even if I didn't necessarily feel that inside. And I told people about it. I talked about it when I could, every time I could, to people who didn't care, to people who did care, to people that I didn't know would care but did. And it was in having these conversations that I was introduced to every person who has directed me to where I currently am. I would also say, choose, to piggyback off of that, choose what you want to study because you want to understand your disease of interest and you want to cure patients. Don't choose it just because you want to put surgery in the mix. Don't, like I said, don't try to force surgery because it's just what you do. Surgery is going to have a role. Surgery is extremely important and always is going to have a role, and it's your responsibility to figure out where. I feel really strongly about this idea of choosing surgery and using it wisely, not because I want to discount it, but because I love and respect it. In order to ensure that everyone else around you who does not participate in it in the same way that we do, also respects it as they should, we have to do our best to apply it in ways that are intelligent and to let others know that we also understand the disease that we're dealing with as well or better than they do. And that will provide the best chance of success in aiding our patients and also make sure that surgery is not discounted inappropriately in places where it may actually help. And lastly, I think it's very important to know and to make the decision that you love being part of a team if you're going to be doing research. And to have that and to have the success of the outcomes in what you're trying to study drive you forward as opposed to your independent success. And so in spite of my original comments regarding the competition that exists for resources and ideas from all the stakeholders in biomedical research, It's even more important to view each of these parties as contributors to the complete understanding of your disease of interest and to always aim to collaborate as extensively as possible. Biomedical research is too complicated to be able to succeed alone. And frequently, as surgeons, we're trained to act independently as possible, and there's a good reason for that in order for us to be able to get our clinical jobs done safely. But in today's day and age, that approach really doesn't work for research. And the most massive contributions to the biologic understandings in various diseases are the results of huge collaborations from groups with different perspectives, different techniques, and different levels of understanding of the disease. And building relationships between all these groups and approaching surgery in a way that allows everyone to weigh in, contribute, and succeed is extremely important, but it's also a large part of the fun of the work. And every day, I'm amazed at the opportunities I have at my job due to the fact that there are an incredible team of people that I get to work with different expertises and different perspectives. So I'd like to firstly say a large thanks to Trudy and the Oliver Lab, which has grown rapidly in this short time since I've started. And Trudy has demonstrated to me, most importantly, I think, an excellent leadership style in which she is highly understanding, but maintains extremely high standards, both for herself and all of the people that she works with. And she also pairs this with excellent communication. All right, this is Trudy. In addition to her creative approach to science and her insistence at looking at data very honestly, it is her leadership which has allowed her so much success. And I want to particularly thank Anna Long, who is here, who is my personal laboratory technician. And she is very tenacious, incredibly thorough. And it is her that allows me to continue doing my clinical work while the lab keeps moving forward. I also cannot express enough how the clinical partners I've inherited through my current position have strengthened my belief that we can make meaningful progress in the realm of small cell lung cancer. Both Doctors Alder and Clark are small cell lung cancer enthusiasts in the medical oncology department at Duke, and they are experienced clinical database researchers and clinical trialists. Hui-Hua Lee is an excellent thoracic pathologist who has a love for translational science and is irreplaceable in regards to our work with human tissue. And then finally, even though he's not at Duke, Jeff Yang remains one of the strongest advocates for the clinical utility of surgery in small cell. And his national connectedness and efficiency will be imperative from a national and international perspective in allowing the coordinations of small cell lung cancer, as it's a low incidence disease, and we're going to need to work on this at a multi-institutional level. And I could also not ask for better surgical partners, and their teamwork makes it possible for me to even consider developing a scientific career while simultaneously practicing clinical surgery. I'm eternally grateful to their support and their undying belief in the work that we do. And lastly, I could not come back to Colorado and ignore the mass transplantation of my general surgery co-trainees to our new home in the Triangle. And I was informed last night that I'm missing some people on here, so I'm very sorry, but that just means even more people are out there and I didn't even realize. So Maggie Hodges is doing wonderful things in MIS and bariatrics just down the street at UNC. And she has been my first call for bariatric associated foregut issues that I come across on call. Joss Billings is doing great under her tutelage as her fellow. Of course, Doug Overby is now a prolific congenital cardiac surgeon, and he's my partner in the Division of Cardiothoracic Surgery at Duke. In spite of our disparate clinical specialties, he, of course, found some way to rope me in to a combined clinical effort with him and make myself invested in a fully minimally invasive program to manage vascular rings of the great vessels. And so I'm now routinely doing robotically divided comrolls with him. And it's just like being his junior resident again, which I was for the vast majority of my third year in general surgery residency. And then Navin is doing great things as our second year fellow. And he and I have also returned to our previous training relationship, as he was my third year resident for the majority of my chief year. And I'm still working on getting him to be gentle enough with the pulmonary artery, as can be seen in our lab simulation last week when our ketchup blood spilled all over the place, but we're getting there. And certainly not least, Greg Stetler is just a stone's throw away up at Wake Forest in his faculty at the Division of Trauma Surgery. And my surgery class and I have certainly remained a family and forced our spouses to join the fold, even those who didn't get the memo to relocate to the Triangle. We continue to challenge and inspire each other, including getting some of us to compete in our first triathlon this year. We're both Greg and Jeff, who is surgical oncology at Pittsburgh. We're joined by Lyndall Dewberry, who is now an amazing pediatric surgeon's husband. This is Ben, and my husband, Kyle, competed in their, as I said, their first triathlon and did great things. So I want to thank you all very much for this. And just as a reiteration to all the trainees, this is a wonderful place to train, and I couldn't have asked for anywhere better. So thank you very much.
Thank you. We're going to have some questions, and then we're also going to have a event at 5101 in A01 where we're going to go over some topics in a smaller group about becoming a surgeon scientist and things of that nature. But one question I have is, how transformative was Dr. Oliver's visit to Memorial Sloan Kettering, and the fact that she was researching something that you were very interested in? And was that a relationship that you had before that, or was that something that really exploded after that visit? And
yes,
talk about that a little bit.
It definitely exploded after that visit. I do think it's important if you're coming into any position, but your first position, and you don't have a lab yet, or if you have a lab, it's extremely small, and you want to build one at the place where you're going to go. A large part of your negotiations with your bosses is, what does that mean? Where is it going to be? Where is the money coming from? Where is the space? And who is going to be my predominant scientific mentor? And you should and can do a lot of that legwork by looking to see who is on faculty at the places that you're interested in, to see if there are people that you can meet with. And you can ask to meet with those people when you come to the interviews. They'll ask you, is there anyone that you want to meet with? And you can say, and you can try to build relationships with those people. And so it's important to understand, when you do meet with people you could potentially collaborate with or use as a scientific mentor, is there a good relationship there that makes can you talk with them? Is communication easy? And from a practical perspective, do they have the space to support you in their lab? And so those are two important questions to ask. I will say that it maybe was a little backwards in my circumstance, because I had an initial phone interview for the Duke position, and I didn't know that Trudy was at Duke at that time. She had just moved there. And I mentioned my interest in small cell, and for whatever reason, Tommy D'Amico was aware that Trudy had just been hired. And so he mentioned her and said, and that's when I started to look a little bit more into her recent publications and realized this was something that was actually going to work. I did not know the details of her work before that happened. And her coming to MSK was something that happened sort of after the fact. So where we just sort of were able to meet and solidify our relationship a little better.
Yes, Dr. Schulich.
So Dr. Bevers, congratulations. We're all very proud of you, and we really look forward to following your career trajectory. I think you're doing exactly the right thing, focusing on your surgical practice, but embedding with a bunch of experts in a scientific area that you're really interested in. I would be remiss if I didn't mention Dr. Steve Yang, who is on my right here, who's another thoracic surgeon and mentored both Rob McGee and myself and many others. And so we're in the presence of a lot of great thoracic surgeons today. My question to you is, have you seen patterns, whether it is genetic, proteomic, metabolomic, whatever, that you can triage patients who are more likely to benefit from a surgical resection versus the great majority who will not benefit from a surgical resection?
To some degree, yes. I will say one of the unfortunate things, even though we have this classification system, really right now that's not good enough for clinical prime time. And part of that has to do with the fact that every tumor expresses a little bit of all of those things. And when you are operating on the decision, to operate or not based on a surgical biopsy, sampling bias can influence how you know about the biology. So right now, we still are limiting most of our resections to these peripheral small tumors. I will say, and this is something Trudy's very interested in, and we sort of there are ways that we're trying to discover this, but there's something very different for one reason or another about the biology of tumors that arise centrally as the biology of tumors that arise in the periphery. I've actually never seen a clinical T stage 1 small cell lung cancer centrally that did not have lymph node metastasis or distant metastasis. I don't even know that clinically exists. The philosophy associated with the lab is that this is due to the fact that there's a belief that the biologic idea of small cell lung cancer is actually a convergent evolution of problems that are arising from different cells of origin. And so the cells in the periphery of the lung and the cells in the center of the lung are not the same. And there's the work that's predominantly being done by Trudy and then her amazing PhD candidate, Abby is amazing, is focused on trying to identify these cells of origin as a marker. So if there is work that comes out of that, there may be some genomic associated profiles that could be gained looking at what cell of origin predominance is in a biopsy sample, and that could direct some therapeutic indications. We're not there yet clinically, but.
Could it also be that, you know, in the center of the lung, you're off I-70, and in the periphery of the lung, you've
got longer to go. You got longer to go. There is possibility associated with that, yeah.
Dr. McGee.
Dr. Bevers, congratulations. It's so exciting to see you flourish and come from beginnings here and succeed at Duke. Thank you for sharing with us your story as well as talking about what you've needed to do to leverage that early success. As a thoracic surgeon, what you said strikes me that with the increased use of immunotherapy, we're starting to see more frequent episodes where we have conversion of non-small cell to small cell, and showing the biology. That's quite interesting to see. Have you thought about starting a specific registry for these types of tumors? It would obviously be multi-institutional. You'd have to get medical oncology involved. We barely see small cell here because they get triaged directly to medical oncology unless it's a peripheral low stage. What are your thoughts on that to build a national or international registry for this?
So we are very excited about potentially doing something like that. Dr. Alder and I are attempting to spearhead that at Duke right now, and there's some interest in places around the country.
There's interest here.
Good. We debated with ourselves about how to approach it. Small cell, as a whole disease has a low incidence. And one of the other difficulties with it is even still preoperative diagnosis isn't always clear. Depending on the experience of your pathologist, you can easily get a biopsy that calls something a carcinoid, and then it comes back as a small cell. So how do you enroll patients in this when they haven't had surgery yet? And so we've debated on whether or not just creating a neuroendocrine database, not to go too far off piste, but there's also a lot of interest within our group trying to define how large cell neuroendocrine tumor may be related to small cell and where that biology lies. So I think there's probably a benefit in collecting all neuroendocrine tumors holistically to try to describe their relationship and to make sure you're not missing any. We are in discussions with some experienced people at UNC about the idea of generating a post-mortem tissue collection program for small cell, in addition to trying to collect early stage disease, in order to, because this I think is, I spoke that most of my work focuses on early stage, but you also want to create tools that everybody can use to study the disease. And in order to really understand what's happening in late stage disease, you can't just focus on biopsies from individual metastasis or from the primary site. So a post-mortem collection program allows you to take samples from every single metastasis, normal tissue as well, and do comparative omics on all of those things. Not to be morbid, but there is a very short time frame between the time that a person is diagnosed with small cell and the time that they would potentially be a candidate for such enrollment. UNC has had a lot of success in utilizing a program like this for breast cancer. And I know that there are state-by-state regulations on the ability to make these things happen, but North Carolina has a system where it is possible. So we're in the process of trying to make decisions about building something like that as well. But so it's a lot of different concepts of tissue collection, we do want to have our tissue bank for the more early stage disease be done in conjunction with development of a clinical database so that the clinical outcomes can speak directly to the biologic principles.
All right. As you know, being a resident here, that you don't get to come and visit
Yes.
without the ubiquitous swag bag.
Thank you.
So, there's the usual things in there. So we really want to thank you for coming. I thought that was outstanding talk, great discussion. Exactly, we have that.
have
And
one
we're
already.
gonna reconvene at 5101 and do some Q&A about career as a surgeon scientist. So thank you very much and enjoy your day.